Ovarian tumor is one of the most common tumors of female generative system. Little progress has been made in identifying in situ changes of this lesion, but still ovarian cancer accounts for 6% of all cancers in the female, and it is fifth most common form of cancer in women in the United States. The normal ovaries occupy the ovarian fossa of the lateral pelvic wall, overlying the ureter, but are attached to broad ligament by the mesoovarian, to the pelvic side wall by the infundibulopelvic ligament, and to the uterus by ovarian ligament. Blood supply is from the ovary artery, but there is anastomosis with branches of the uterine artery into the broad ligament. The ovaries have an outer cortex covered by germinal epithelium. The most common carcinoma derives from this layer. The inner medulla consists of connective tissue of blood vessels. The cortex contains the follicles and theca cells. Estrogen is secreted by granulosa cells in the growing follicles and also by the theca cells. The rare tumors of these cells secrete estrogens. A few follicles start to enlarge every month under the influence of pituitary follicle stimulation hormone, FSH. But only one will reach about 20 millimeters in size and rupture in response to the mid-cycle surge of pituitary luteinizing hormone to release its oocyte. After ovulation, the collapsed follicle becomes a corpus luteum, which continues to produce estrogen and progesterone to support the endometrium, whilst awaiting fertilization and implantation. If none occurs, then the corpus luteum involutes, hormone levels decline, and menstruation begins. If fertilization and implantation occur, then human gonadotropin produced from trophoblasts maintains corpus luteum functions and hormone production until 7 and 9 weeks gestation, when the fetoplacental unit take over. Follicular and lutein cysts result from persistence of this structure in non-pregnant women. Risk factors for ovarian tumors, it may be multiparity, infertility, early menarche, late menopause, endometriosis, family history, talc use, prolonged use of ovulation-inducing drugs, protective factors, oral contraceptive, pregnancy, breastfeeding, tubal ligation, hysterectomy, and prophylactic salpingo-oophorectomy. Ovarian lesions divided in non-neoplastic lesions and neoplastic lesions. Non-neoplastic lesions have two types: functional ovarian cysts and endometriomas. Functional ovarian cysts consist of follicular cysts, corpus luteum cysts, theca luteum cysts, and most common ovarian lesions in the reproductive years. All are benign and usually asymptomatic. The most common functional cyst is follicular cysts. Follicular cysts vary in diameter from 3 to 8 centimeters. Histologically, they are seen to be lined by inner layer of granulosa cells and an outer layer of theca internal cells that may or may not be luteinized. These cysts result from a failure in ovulation, most likely secondary to disturbances in the release of pituitary gonadotropins. The fluid of incompletely developed follicle is not reabsorbed, producing an enlarged follicular cyst. Typically, follicular cysts are asymptomatic, also bleeding and torsion can occur. Large cysts may cause pelvic pain, dyspareunia, and occasionally abnormal uterine bleeding associated with a disturbance of the ovulatory pattern. When it's come to treatment of follicular cysts disappears spontaneously within 60 days without any treatment. Use of oral contraceptive pills has been recommended to help establish a normal rhythm. However, recent data shows that this practice may not produce more rapid resolutions than expectant management. Aspiration of follicular cysts were performed in the past, and nowadays it is not recommended. This is a picture of follicular cysts. So it is easy to diagnose this cyst by ultrasound examination. Corpus luteum cysts. These are seen walled unilocular cysts ranging from 3 to 11 centimeters in size. After normal ovulation, the granulosa cells lining the follicle become luteinized. In this stage of vascularization, blood accumulates in the central cavity, producing the corpus hemorrhagium. Reabsorption of the blood then results in a corpus luteum, which is defined as a cyst when it grows larger than 3 centimeters. A persistent corpus luteum cyst may cause local pain or tenderness. It also can be associated with either amenorrhea or delayed menstruation, thus simulating the clinical picture of ectopic pregnancy. A corpus luteum cyst may be associated with torsion of the ovary, causing severe pain, or it may rupture and bleed, in which case the patient presents with a peritoneal signs and acute abdomen. When it's come to treatment, laparoscopy or laparotomy is usually required to control hemorrhage into the peritoneal cavity and to perform the torsion of the adnexa. Unless acute complication develops, symptomatic therapy is indicated. As with follicular cysts, the corpus luteum cysts usually regress after 1 or 2 months in menstruating patients, and oral contraceptive pills have been recommended by maybe a question of benefit. Theca lutein cysts. Elevated levels of chorionic gonadotropin can produce theca lutein cysts, and those are seen in patients with hidatidiform mole or carcinoma, and in patients undergoing chorionic gonadotropin or clomiphene therapy. Rarely they are seen in normal pregnancy. The cysts are lined by theca cells that may or may not be luteinized, and they may or may not have granulosa cells. They are usually bilateral and are filled with clear straw-colored fluid. Abdominal symptoms are minimal. Also, a sense of pelvic heaviness or aging may be described. Rupture of the cysts may result in peritoneal bleeding, continued signs and symptoms of pregnancy, especially hypermenesis and breast paresthesia are reported. Treatment of the cyst. This usually disappears spontaneously after termination of the molar pregnancy. Treatment of choriocarcinoma or discontinuation of fertility therapy. However, such resolution may take months to occur. Surgery is reserved for complications such as torsion and hemorrhage. So one management for all functional cysts, it is waiting for 2-3 cycles to cease to disappear spontaneously. It's taking taking oral contraceptive pills, and should cyst persist, surgical management is often indicated. Endometriomas. In a woman with endometriomas, endometriotic foci on the ovarian surface may develop a fibrous enclosure and manifest cyst formation as a result of accumulation of fluid and blood. These endometrial cysts vary from several millimeters to even 10 and more centimeters in size. Endometriomas are also referred to as chocolate cysts because they contain thick brown blood debris inside. Endometriomas are usually associated with chronic pelvic pains, dyspareunia, dysmenorrhea, and infertility. Malignant transformations is 0.3% to 0.8%. So when it comes to management, it can be medical or surgical, but the tumor marker CA125 is commonly elevated in this form of cyst, which creates a serious clinical problem in distinguishing these cysts from malignant epithelial tumors. So this is a picture of endometriomas. They can be big in size, and in the cut we can see that cysts consist from brown blood debris inside. Ovarian neoplasms. Ovarian neoplasms may arise from any histologic elements of ovary and are most often benign, especially in premenopausal women. The characteristic of the mass and the age of the patient are important factors guiding diagnosis and treatment. The overall risk of malignancy of ovarian cyst is 13% in premenopausal women versus 45% in a postmenopausal woman. So, neoplastic ovarian lesions has primary ovarian tumor and secondary ovarian tumors. Primary ovarian tumors classification by nature: benign, borderline, and malignant. Classification by organ: epithelial, sex cord stromal, and germ cell. Epithelial tumors. Epithelial tumors occur for approximately 60 to 80% of all true ovarian neoplasms and include the common serous tumor, mucinous tumor, endometrioid tumor, clear cell tumor, Brenner tumor, and mixed tumors. Most tumors presumably arise from invaginated surface epithelium and proliferation of malignant degeneration in the epithelial lining of the resulting surface inclusion cysts. The epithelial tumors are classified on the basis of their histologic appearance. Epithelial ovarian tumors, serous tumors, 10% bilateral, 70% benign, 5 to 10% borderline, 20 to 25% malignant. Epithelial ovarian tumors, mucinous tumors, are huge in size, multilocular, and 85% benign. Renal tumors are solid and benign. Serous tumors have been reported in all age groups and are responsible for approximately 50% of all epithelial ovarian neoplasms. Low-grade neoplasms generally are found in patients in their 20s and 30s, whereas their antiplastic counterparts occur more commonly in premenopausal and postmenopausal women. So, serous cystadenomas are benign lesions, commonly unilocular with a smooth surface and contain thin, clear yellow fluid inside. The cells lining the cyst are a mixed population of ciliated and secretory cells similar to those of the endosalpinx. They may grow large enough to fill the abdominal cavity, but usually they are smaller than their mucinous counterparts. Papillary serous cystadenomas, benign serous tumors. They are bilateral in approximately 50 to 20% of cases, sometimes to 30 to 50% of cases. Focal proliferation of the underlying stroma may produce firm papillary projections into the cyst, forming a serious cystadenophybroma. So, papillary serous cystadenomas, unilocular or multilocular thin walled cyst, has intracystic or external papillae, contains serous fluid with blood. In 30–50% they can be malignant. Serous tumor, the malignant form called serous cystoadenocarcinoma and serous papilliferous carcinoma. This is a picture of serous simple cystoadenoma. So they can be in different sizes. They can be huge and small. Sometimes they can be as huge as they may grow large enough to fill whole the abdominal cavity, and usually they are contain yellow fluid inside. This is a picture of papillary serous cystoadenoma. Mucinous tumors. These tumors account for approximately 10 to 20% of all epithelial ovarian neoplasms, of which approximately 75 to 85% are benign. The benign tumors are typically found in women in their 30s through 50s. Bilateral tumor development occurs in 8 to 10% of all cases, whether the tumors are benign or malignant. So they are largest tumors found in the human body. 15 reported tumors have weight more than 70 kilograms. As the more massive tumor, the greater the possibilities that it is a mucinous tumor. They generally are asymptomatic, and patients present with either an abdominal mass or nonspecific abdominal discomfort. In postmenopausal patients, luteinization of the stroma rarely may result in hormone production, leading to associated endometrial hyperplasia with vaginal bleeding. During pregnancy, hormonal stimulation may result in virilization. So clinical picture, myoma peritoni, rupture of the cyst leads to implantation of the tumor cells on the peritoneum, which produce mucin leading intestinal obstruction. So they can be huge. They are the largest tumors found in the human body. Histologically, they are usually smooth-walled. True papilla are rare. The internal surface is lined by tall columnar cells with dark and basally situated nuclei and mucinous cytoplasm. The study of mucinous neoplasm has shown that histologic appearance may vary greatly from area to area. So in some areas of the tumor, it can be benign, whereas other of the low malignant potential or are frankly malignant. Brenner tumor, rare form of tumor. 2 to 3% of ovarian tumors are Brenner tumors. Usual benign, turns to malignancy in 5%. Small, solid with smooth surface, rarely bilateral. Brenner tumors are considered benign. Also, a malignant variant has been identified. Clinical picture can cause pressure on estrogen producing cell in the ovary, leading to estrogen production and abnormal uterine bleeding. On section, Brenner tumors are firm and pale yellow or white. The epithelium is composed of nests of cells with ovoid nuclei having a prominent longitudinal groove. Other rare forms of epithelial tumors are endometrioid tumors and clear cell tumors. Endometrioid tumors are characterized by proliferation of benign non-specific stroma in which bland endometrial type glands may be found. The only clearly recognizable benign endometrioid tumors are the uncommon endometrioid adenofibromoma and the proliferative endometrioid adenofibroma. Clear cell tumors, like the endometrioid tumors, in their benign form are rare and are virtually limited to clear cell adenofibromas, in which a solid proliferation of nonspecific stroma contains small cytologically bland glands formed by columnar cells with clear cytoplasm. The clear cell component usually coexists with another epithelial type. Clinically, they appear like any other benign ovarian mass and are diagnosed only on histologic examination. Primary ovarian tumors. Second type of primary ovarian tumors is germ cell tumor. It can be benign and malignant. Benign major cystic teratoma and immature solid teratoma. Malignant immature solid teratoma, dysgerminoma, yolk sac tumor, and non-gestational choriocarcinoma. Germ cell tumors common in children and young females. Less than 20 years, 80% of ovarian malignancies. Benign cystic teratoma, 10 to 50% of all ovarian tumors in young age. Bilateral in 15 to 25%, turn malignant in 1 to 3%. Major cyst teratomas, commonly referred to as dermoid cysts, compose some 40–50% of all benign ovarian neoplasms. They contain well-differentiated tissue derived from any of 3 germ cell layers, including hair and teeth as ectodermal derivatives. They account for the majority of benign ovarian neoplasms in reproductive age women and usually are asymptomatic unless complications such as torsion or rupture occur. So dermoid cysts cross appearance moderate in size 10 to 50 centimeters. They are thick, whitish, smooth surface in cut section, cystic, unilocular, and containing sebaceous material with offensive odor, Rokitansky skin noodles showing hair, bone, teeth, and microscopic appearance of 3 germ layers. So this is a picture of dermoid cyst. How you can see in the picture, inside the cyst, it's maybe teeth, hair. In this picture, you can see the hair. So there can be any of 3 germ cell layers, hair, teeth, and ectodermal derivatives. So when it comes to clinical picture, mass found anterior to the uterus because of the long pedicle. They are asymptomatic, but risk of torsion is 15% or rupture causing peritonitis. Struma ovary teratoma contain thyroid tissue that produce T4 cells. So also most major teratomas contain cells from all germ cell layers. A subset of monodermal teratomas exists. Those tumors composed mostly or entirely of thyroid tissue are called struma ovary. These tumors account for only 3% of all teratomas, and only 5% of these will produce symptoms of thyrotoxicosis. So struma ovary teratomas contain thyroid tissue and they produce T4. Another type of germ cell tumor, dysgerminoma, it's a rare form of tumor occurring usually in young ages, may occur in dysgenetic gonads, cross appearance, unilateral, solid, rapidly growing with areas of hemorrhage and necrosis. Low-grade malignant tumor, spread only by lymphatics, and it is radiosensitive. Yolk sac tumor, second most common malignant ovarian germ cell tumor, occurs in any age, in childhood, in adolescence, and in adult life, and can be pure of a component of a mixed germ cell tumor. Almost always unilateral, solid or solid and cystic tumor. Tumor marker for this tumor is alpha-fetoprotein. Another type of germ cell tumor is choriocarcinoma. It consists from gestational choriocarcinoma, non-gestational choriocarcinoma, and the tumor marker is chorion gonadotropin. Sex cord stromal tumor consists of granulosa cell tumor, androblastoma, gynandroblastoma, tecoma, and fibroma. Granulosa cell tumor is a rare tumor. It's solid, yellowish, smooth surface, usually unilateral, low-grade malignant tumor. Microscopic picture is granulosa cell with coffee bean nucleus. Clinical features for these granulosa cell tumors is that tumor produce estrogen, which may cause irregular bleeding, which may cause postmenopausal bleeding and may bring to endometrial hyperplasia and carcinoma. Fibromas don't produce hormones. They can occur at any age, but most often occur in the years before menopause. They range in size from incidental finding to greater than 20 centimeters. Fibromas are multinodular and whorled, and they are formed from bundles of collagen-producing spindle cells. They can be found as part of Mainz syndrome, in which patient is found to have a pelvic mass in concert with acid and hydrothorax. So only 5% of fibroma are benign ovarian tumors, most common solid tumor, bilateral in 5% of cases, cross appearance, lobulated, has long pedicle causing torsion, and in cut sections, fibromas are solid, whitish, and tuberculated. Tecoma. This type of tumor can occur at any age. Also, they are most commonly found in postmenopausal women. They account for only 2% of all ovarian tumors and may not be true neoplasm, but instead a condition of hyperplasia of the cortical stroma. Histologically, the mass is filled with lipid-containing cells that are similar to TECA cells, and the tumor is known to produce estrogen. As such, these tumors often present with dysfunctional uterine bleeding or postmenopausal bleeding. Occasionally, they have presented with adenocarcinoma of the endometrium, given the unopposed estrogen production by tumors. The tumor range from non-palpable to more than 20 centimeters in size. They are rarely bilateral and rarely malignant. Androblastoma, Sertoli leading cell tumor, is a rare form of tumor. Cross appearance is usually small, solid yellow and unilateral. Microscopic features is Sertoli leading cells and clinical features that they producing of estrogen leads to defeminization and masculinization. This is a picture of androblastoma. So let's overlook to the pathophysiology of ovarian neoplasm. Epithelial tumors derived from the ovarian surface epithelium. They are slow-growing tumors and usually advanced at diagnosis. Makes up 90% of total ovarian cancers. Germ cell tumors derived from cells destined to become eggs. Most common cause of ovarian neoplasms and cancers in female diagnosis. Sex-cord stromal tumors derived from hormone-producing cells or cells that make up the intestine of the ovary. Age of onset is variable. This tumor produces hormones and hence may lead any symptoms not seen in other tumors. Complication of ovarian tumors. So rupture of the contents of ovarian cyst into the peritoneal cavity cause intense pain, particularly with endometrioma or dermoid cysts. Also, another complication like hemorrhage can occur. Hemorrhage into a cyst or the peritoneal cavity often cause pain. Peritoneal cavity hemorrhage is associated to serve as a to cause hypovolemic shock. Also, torsion of tumors may occur. Torsion of the pedicle cause infarction of the ovary tube and severe pain. Urgent surgery and torsion are required if the ovary is to the ovary to save it. So another complication may be infection, malignant changes, and intestinal obstruction. Benign ovarian tumors. The main symptoms of benign ovarian tumors, they may be asymptomatic, discovered accidentally. It's also may be abdominal swelling, pelvic pressure as frequency of micturition, also pain in complicated tumors. And one of the main symptoms is menstrual abnormalities. If the tumor is functioning, if the tumor is producing hormones. And in case of huge mucinous tumor, progressive wasting may occur. Benign ovarian tumors sign may be cachexia, and during abdominal examination, we can see the pelvic abdominal mass, we can palpate it. We can see a surface smooth or lobulated if it is multilocular tumor. It's usually mobile, these tumors, consistency usually cystic, and percussion dual fluid filling ascites. So during the vaginal examination, we can feel mass. This mass is separated during the palpation from the uterus. In diagnostic differential diagnosis, we use 6 F's. It's fetus, fat, flatus, fluid, and full bladder, and fibroid. For diagnosis, this is the main tumor markers. CA125 level should be measured in women over 15 with many abdominal symptoms. These symptoms include persistent or frequent abdominal pain or distension, loss of appetite, weight loss, and urinary frequency or urgency, and in other different symptoms. If CA125 level is raised, an ultrasound of the abdomen and pelvis is arranged. If ultrasound or physical examination identified ascites or a pelvic abdominal mass, urgent referral to secondary care is undertaken. The CA125 is measured and ultrasound is arranged in women, and if woman is under 40, levels of alpha-fetoprotein and human gonadotropin has to be measured to identify women who may not have epithelial ovarian cancer, levels being raised in germ cell tumors. So these markers are important in the diagnosis of ovarian tumors. Also, in diagnosis, we use ultrasound examination, computer tomography, and MRI. Computer tomography scan of the pelvis and abdomen is performed to establish the extent of disease, but Further staging is usually performed using surgery. Surgery can be a laparoscopy or laparotomy surgery, and biopsy also, and sometimes frozen section at exploratory laparotomy may be done. For treatment, if the patient is young, ovarian cystectomy is a choice of treatment. If ovarian tissue is damaged or torsion, then oophorectomy. And if we have tumor associated with uterine pathology, then hysterectomy and bilateral sulfa oophorectomy is recommended.